Henoch-Schönlein purpura, think of lower extremity purpura over the butt and thighs, the posterior thighs, arthralgias, and hematuria. Kawasaki disease, this is an opportunity to talk about rashes that occur on the hands, and that's the mnemonic is Kawasaki cars. Kawasaki disease, Coxsackie A, rickettsia, and syphilis. So Kawasaki disease, the signs are conjunctivitis, strawberry tongue, inflammation around the mouth. They'll have cervical lymphadenopathy, a sore throat, and then a rash on the hands and palms as well. And the key thing here is remembering what's the biggest danger is that they can get coronary aneurysm, which can make them have increased risk for myocardial infarctions or heart attacks. And remember that you treat this with aspirin and IVIG. Lupus has a mnemonic SOAP brain MD, serositis, oral ulcers, arthritis, photosensitivity, blood, as in they can have pancytopenia, renal, as in renal disease with hematuria. ANA is one of the most sensitive markers. Immunoglobulins, they have anti-double-stranded DNA and anti-Smith antibodies. Neuro, they can have psychiatric manifestations, psychosis, and then malar rash and discoid lupus. If you have 4 out of these 11 or more, there's a 99% chance they have lupus. You treat acutely initially with NSAIDs, and then you want to keep them in remission for long-term using hydroxychloroquine, and then for any future flares you want to treat with steroids. Dermatomyositis is characterized by weakness, and then these people have Gottron's papules, which are the erythemas over the knuckles, as well as a heliotrope rash, which is a rash around the eyes, and you treat this with steroids. Remember, dermatomyositis is associated with the underlying malignancy. That's very high yield. They'll also have elevated CPK, which is a sign that there's muscle inflammation and breakdown. If a kid has Lyme disease and they're less than 8 years old, do you treat with doxycycline or amoxicillin? You want to treat with amoxicillin. Why? Because you can't treat doxycycline because doxycycline, what's that main side effect? It affects the teeth. It causes teeth staining, so use amoxicillin. That's high yield. Okay, orthopedics. So kids can have torticollis, which is contraction of the sternocleidomastoid. You treat that with stretching exercises. Down syndrome has a strong association with atlantoaxial instability, which is basically C1 and C2 of the spine is unstable. And then it's also associated with duodenal atresia and Hirschsprung disease. Scoliosis, the kid, tell them to bend over and you'll see that one hump is higher than the other. If it's 20 to 40 degrees, then you do bracing, and if it's 40 degrees plus, you want to do surgery. Spondylolysis versus spondylolisthesis. Spondylolysis is a fracture of the pars interarticularis. Spondylolisthesis is anterior slippage of the lumbar vertebral body. Developmental dysplasia of the hip is very high yield versus SCFE versus leg cavé-Perthes disease. So developmental dysplasia of the hip is due to a malformed acetabulum, which is the hip socket, and the kid will usually have a clunking hip sound. But the main sign here that I want you to look for is the asymmetric thigh or butt folds. That's a big clue. And then you diagnose it with the ultrasound, which will show the malformed acetabulum, and then you treat with a Pavlik harness. Complications are avascular necrosis, and if it's untreated, it can lead to permanent limb length differences, which will be really terrible for the kid later on. Versus SCFE, which is slips capital femoral epiphysis. This is when the epiphysis of the femur slips. And the key thing here I want you to look for is a fat kid around 12 years old is the main demographic that SCFE occurs with. They'll show you an x-ray of the hip. You'll need to be able to see the SCFE, which I'll show you right here. And how do you treat it? Surgical pinning. And then the last one is leg cavé-Perthes, which is basically just idiopathic avascular necrosis of the hip. And then you just treat this with physio, and it usually has a decent prognosis. Versus septic arthritis of the hip versus transient synovitis of the hip. So septic arthritis, the kid usually looks a lot more sick. The hip will or knee will be really red and inflamed. They won't be able to bear weight on it, and they won't want to move it at all because it hurts a lot. It'll also cause systemic symptoms. They'll have fever and leukocytosis. So they usually like to ask you what's the first thing you should do if you see a joint that's red and swollen. The answer, the first thing you want to do is an arthrocentesis. You stick a needle in there and drain it out, and you want to aspirate it and analyze it for how many white blood cells are in there or if there's any bacteria. Usually above 50,000 white blood cells is a good sign that this is septic arthritis, and you want to give antibiotics for it. Whereas transient synovitis, the kid is generally not as sick. They probably won't have a fever, probably won't, the white blood cell in the aspirate will be unimpressive. It'll definitely be like less than 20,000 white blood cells, like maybe around very little, definitely not above 50,000. The key thing I want you to look for here is the kid had an upper respiratory tract infection a week or a few days ago, or like some sort of diarrhea, and now they're having hip pain. But the thing here is they can bear weight on their hip, and it's not as bad as septic arthritis, which is an emergency. If a kid steps on a nail, you have to know what bug this is associated with, and that's Pseudomonas. Genu varum versus genu valgum, which is knocked knees, and the other one where you're bow-legged, and the parents will ask what to do, and usually the answer is reassure. You wait till they're 8 years old, by then it usually resolves. And then we're going to talk about the knee problems. You have Osgood-Schlatter disease, patellofemoral pain syndrome, patellar tendonitis, prepatellar bursitis, and anserine bursitis, and stress fracture. So Osgood-Schlatter is inflammation / little microfractures of the tibial tuberosity, and it's worsened on knee extension, and they have a lot of pain over the tibial tuberosity. So you want to just treat this supportively with rest and stretching. Patellofemoral pain syndrome is pain caused between friction between the underside of the patella and the femur. And when that rubs up against each other, it causes pain. So when you extend the patient's knee and compress the patella at the same time, this causes pain. And that's called patellofemoral pain syndrome. And it's also treated with physio and supportive care. Patellar tendonitis is exactly what it sounds like, pain over the patellar tendon, so just beneath the patella and above the tibial tuberosity, just inflammation there, and you treat that supportively as well. Prepatellar bursitis is when people have repetitive actions on the knees, such as like people who are like mainly carpenters or anyone who does a lot of activities on their knees. This is prepatellar bursitis, and they'll have pain over their patella. Anserine bursitis is pain over the medial aspect of the knee below the joint line. Stress fracture, I want you to remember low BMI, that's the clue. The next is a supracondylar fracture. This is important and very high yield because they're going to ask you, they're going to want you to know if this is an emergency or not. And it is, it's an emergency. Why? Because a supracondylar fracture, which happens at the distal humerus, you have to fix it right away because it's at high risk for compartment syndrome. Compartment syndrome is where you get increased edema and swelling within the compartment. There's the muscles in the arms and legs are all in their own separate compartments and are surrounded by fascia. The fascia has very limited ability to stretch, so when you have edema and swelling within those compartments, it can increase so much pressure that it cuts off the blood supply, and also it can compress the nerves. And if you don't treat this right away, it can be really dangerous with permanent ischemia and necrosis of the distal muscles, and it also can cause permanent nerve damage. So you want to treat this right away. And usually they'll ask you what's the complication, and it's compartment syndrome. And then remember the two fractures of the forearm. The mnemonic is Mugger, M-U-G-R. Montagia is an ulna fracture, and Galeazzi fracture is a radial fracture. You should also know about the radial head subluxation, which is the nursemaid's elbow, which is when the kid is usually like going shopping or something, and then their parent kind of tugs on their hand or like swings them, like when you're playing and you're walking with your parents and they kind of like swing you up. that can cause subluxation of the radial head, and how you treat that is hyperpronation of the forearm and then flexion. And that can be fixed. Things to suspect abuse fractures, spiral fractures, metaphysis fractures, posterior rib fractures, or the first rib. Also, sometimes in a vignette, it helps to know the pediatric milestones, because the parent might say something like, oh, the kid who's 8 months old climbed up the couch and then jumped, like fell down and hit his head. And then you should know that a kid who's 8 months old can't climb up the couch yet. And then that should suspect abuse. And then the things you want to do with abuse, like a kid who has a head injury, is do fundoscopy and then do a bone x-ray to check for suspicious fractures. And they might also have bruises that are of different ages. And then the first thing you want to do before you analyze any of that is you want to separate them from their parents. So you admit them to the hospital and then you do all that. Another thing you might see is like burns that are not natural. So natural burns from hot water splashing will have like irregular like splashing marks, whereas like a burn from dunking will have like a straight line, and then the creases of the skin are spared. So that's another sign of abuse as well. Kids who have sudden changes in attitude, like they used to be a happy kid and then they have a sudden change in attitude, now they're always depressed or their grades are falling, you should suspect abuse as well. And then if a kid is in there with their parent, you always want to separate them from their parent and talk to the kid alone. And then also you want to call Child Protective Services. But the one thing I want you to remember is the first thing you do, if you see the option of what is the next best step, you want to admit the kid to the hospital to separate them from their parents. If that's not there, then look for the other things I talked about. Amblyopia is important because this can cause permanent blindness in the eye. So things that can cause this is early cross-eyedness, strabismus, or cataracts. When kids are fairly young, they really need a lot of light stimulation to their retina to activate that part of their brain of vision. If it doesn't happen, then this can cause blindness. So you want to fix strabismus as early as possible and cataracts. Conjunctivitis, you should know the timeline. There's 4 types: chemical, gonorrhea, chlamydia, and herpes. So chemical happens in the first 24 hours, so the timeline is important. Gonorrhea happens on days 3 to 5. It's very purulent. You treat it with topical erythromycin. Nowadays, they just give kids topical erythromycin right away as soon as they're born. Chlamydia happens more like days 7 to 14, and you give that with oral erythromycin. Topical won't work. And then herpes is days 14 and on, and it's more of like a unilateral conjunctivitis. A kid who is born with herpes, look on the top of their head, their scalp, you might see vesicles on the scalp. Blepharitis is inflammation of the eyelid, and this can cause crusting of the eyelashes in the morning. It's usually Staph aureus, but here you treat it with just eyelid shampoo. No need for antibiotics. Bacterial conjunctivitis, on the other hand, is different. It'll have a bilateral purulent discharge. It could be unilateral as well. It'll have purulent discharge, and the most common bugs are strep pneumo, H. flu, and Marxella as well, which kind of is a recurring pattern of infections in the recap: sinusitis, bacterial conjunctivitis, acute otitis media, pneumonia. And so for bacterial conjunctivitis, you want to treat with erythromycin. Viral conjunctivitis is most commonly caused by adenovirus. It's also known as pink eye. It's highly contagious. The kid can also have a mild fever with a runny nose as well, and the parent will ask when can they go back to school. They can go back to school once the eye discharge stops, and you treat this. Hyphema is blood in the anterior chamber of the eye. Last is retinoblastoma. The main thing to look for is a loss of red reflex in like a photo or upon pupillary exam, and this is a tumor in the retina, and this needs to be treated right away. So what's the difference between lotion, cream, and ointment? Lotion is used for minimally dry skin, cream is for moderately dry skin, and ointment is for maximally dry skin. Diaper rashes, parents, this is also key too. They always want you to know the difference between irritation dermatitis, like an actual diaper rash from irritation from feces and urine, versus candida. They both have a diaper rash, but the candida one involves the inguinal creases, whereas the non-infected diaper rash is just more confined, doesn't involve the inguinal creases. Candida will also have satellite lesions, which are little papules that are not connected to the actual main rash. The candida diaper rash will be treated with azoles, whereas the non-candida diaper rash is treated with zinc paste. Pityriasis rosacea is the Christmas tree pattern that starts with the Herald patch. You treat that with antihistamines. Tinea, you need to know about Tinea capitis. It can have patchy hair loss, broken hairs, and little scales on the head. This is a type of fungus by trichophyton. It can also have occipital lymphadenopathy. The main question they always ask is, how do you treat it? It's oral griseofulvin. Versus Tinea pedis, which is athlete's foot. It can also affect the nails, which make it look thick and yellow. This is treated with oral terbinafine. Tinea versicolor is hypopigmented areas over the back and shoulders. You treat this with selenium sulfide, also known as Selsun blue. Molluscum contagiosum, it's very contagious. It's also associated with HIV, and you treat it by observation. Hair lice is treated with permethrin shampoo and a comb. Pubic lice has black papules or blue macules, and you treat with benzene lotion. Scabies is extremely itchy, especially at night. Look for lesions, especially in the webs of the fingers. You treat the whole house because it's super contagious. All the clothes in the house and bed sheets, hot water washing, and all the clothing and bedding, and you put them in plastic bags and like basically quarantine it. Might as well just burn it. You treat the patient with a whole day of permethrin lotion. Vitiligo versus albinism. Vitiligo is autoimmune and you have loss of melanocytes, whereas albinism, the melanocytes are there, but it's the melanin that is unable to be synthesized. The melanin gives you pigmentation. So vitiligo is treated with Sorolin and albinism is not treated. Alopecia, you have areata, totalis, and universalis. Alopecia areata is patchy hair loss. It can be treated with intralesional steroids. Alopecia totalis is you have the whole entire scalp is bald, whereas alopecia universalis is the whole entire body is bald, including the eyebrows. Acne, remember, it can be caused by skin shedding, plugging the ducts, sebum, or it can be caused by a bacteria known as P. acnes, and you want to treat it in different tiers. So first you try topical retinoids or topical benzoyl peroxide, and then if that doesn't work, then you advance to topical antibiotics. If that doesn't work, then you advance to oral antibiotics. If that doesn't work, then you advance to oral retinol, which is also known as oral isotretinoin, which is also known as Accutane. The thing about this is it's extremely teratogenic, so if any teenage female who wants to take it, you always have to do a pregnancy test and put her on contraceptive medication so that she doesn't get pregnant. Emergency medicine. So the most common cause of cardiac arrest in a kid is lack of oxygen to the heart due to a lung problem such as choking or drowning. Anaphylactic shock is an extreme allergic reaction, usually to foods. Common ones would be like peanuts or like bee stings, and it's a histamine mediated vasodilation which causes shock, and the first thing you want to do is treat with intramuscular epinephrine 1 to 1000. Also give IV fluids. Septic shock is actually due to leaky vessels due to inflammation and nitric oxide release. That is due to an overwhelming infection. You treat that with fluids and antibiotics. At what Glasgow Coma scale do you intubate? It's 8. If the score is 8 or lower, you intubate. How do you treat increased intracranial pressure? 3 things: hyperventilation, elevate the head of the bed, and mannitol. Burns, you should know the difference between a 1st degree, a 2nd degree, and a 3rd degree burn. A first degree burn is usually looks like a sunburn. A second degree burn starts to have blisters, and a third degree burn has the white leathery look to it, and at that point there's no pain anymore. Key smell associations: if it smells like almonds, think of cyanide poisoning. If it smells like garlic, think of arsenic poisoning. Cherry color skin association, think of carbon monoxide or cyanide poisoning. If there's a gray cyanosis, think of methemoglobinemia. If a kid had some sort of caustic ingestion, like they drank toilet bowl cleaner or drain cleaner, the first thing you want to do is remove all the clothes, and the second thing you want to do immediately is endoscopy to assess for damage. That's very high yield. Overdose antidotes: beta blocker overdose, treat with glucagon. Aspirin overdose, you want to treat with sodium bicarb and charcoal and gastric lavage. Remember, toilet bowl cleaner is acidic, whereas drain cleaner is basic. So they can cause different histological manifestations that you should know. The acidic ones, like toilet bowl cleaner, causes coagulative necrosis, whereas the alkali ingestions, such as drain cleaner, causes liquefactive necrosis. So the bleaches and the laundry detergents and drain cleaners are alkali. That causes much deeper damage. Remember, the first thing you want to do after you remove all the clothes is endoscopy to assess the damage. Cat bites, dog bites, and human bites are all treated with augmentin, which is amoxicillin plus clavulanic acid. The dog and cat bites carry Pasteurella, whereas the human bites have multiple different bugs. And usually the human bite will be like someone was in a fight and their knuckles got cut. Von Gurke is a glucose 6-phosphatase deficiency. Just remember, these are really hard to remember, these next ones I'm talking about. So remember some of these key facts and try your best. So hypoglycemia and a lot of ketones, lactic acidosis, doll face, that's von Gurke. Goucher disease is glucose cerebrosidase deficiency. There's going to be bone pain, hepatomegaly, and crumpled macrophages. Remember, this doesn't include everything, but I'm trying to give you buzzwords to help you give you the best chance possible on these multiple choice questions with these rare metabolic diseases that are very hard to remember, instead of just like taking the L on them. You should also know the difference between syncope versus seizure, because if someone has syncope, then there will be no post-ictal state, whereas someone with a seizure will have a post-ictal state, which means after they wake up, they're confused. So that's kind of the main difference. If they're not confused, then you can start thinking of other causes of syncope. The most common ones are orthostatic, vasovagal, and arrhythmogenic. So a kid with the first febrile UTI, the first step you want to do is a bladder and renal ultrasound. When do you do a vesicocystolurethrogram? A VCUG is hydronephrosis, recurrent UTI, or a UTI due to some abnormal bug other than E. coli. And then the last one is what we talked about earlier, was a posterior urethral valve. If someone has epiglottitis, the symptoms is the kid will assume the tripod position like this, and they'll be drooling a lot and they'll have difficulty breathing. This is caused by H. flu, which is also vaccine preventable. And the first thing you want to do, the correct answer will usually be intubate. Key trick here for the microcytic anemias, remember the mnemonic FAST for microcytic anemias, FAST. Iron deficiency anemia, anemia chronic disease, sideroblastic anemia, and thalassemia. The next thing you want to look at is the red cell distribution width. If it's an increased RDW, then that's going to be iron deficiency anemia. Thalassemia will have a normal red cell distribution width. And then anemia of chronic disease is there will be hints of some sort of chronic disease or inflammation. And that person will have increased ferritin and decreased serum iron, decreased TIBC. And then sideroblastic anemia, this person will usually have increased ferritin, increased serum iron because the iron is spilling out of the cells, and then decreased TIBC. Friedreich's ataxia, I want you to remember three things: ataxia, scoliosis, and hokum. They like to ask what's the cause of death in Friedreich's ataxia. It's due to hokum, and also remember that it's a trinucleotide repeat disorder. Remember the sequence GAA. Erythema neonatorum toxicum. It's a rash that shows up in the first 2 weeks of life, goes away on its own. They usually ask you what the biopsy will show. It's eosinophils. Celiac disease, inability to tolerate gluten-containing foods. It causes villus atrophy. This villus atrophy will cause the patient to not be able to absorb iron or also absorb fat-soluble vitamins, the vitamins T, E, A, and K, because that's where your fat-soluble vitamins and iron are absorbed, is at the duodenum, where celiac disease is often affected. And how you treat it is to avoid gluten-containing foods. The antibodies involved will be anti-transglutaminase antibodies or anti-gliadin antibodies. DeGeorge syndrome, remember DeGeorge is the mnemonic catch-22. So cleft lip, abnormal facies, no thymus, cardiac defects, and hypocalcemia, and 22 stands for chromosome 22. This person, since they have no thymus, will have no T cells, so they'll get a lot of opportunistic infections similar to someone with HIV. And then they will also have hypocalcemia, which causes Trousseau's sign and Chopstick sign. Chopstick is when you tap the cheek and it causes paresthesias and muscle spasms. And then carpal pedal spasm is the Trousseau sign, where the blood pressure cuff it's increased, it causes carpal pedal spasming. And then the cardiac defects, it's usually truncus arteriosus and tetralogy of Fallot. Bug bites on the cheek can extend to the orbit and cause orbital cellulitis. What they want you to know is if you know the difference between preorbital and orbital cellulitis. So the orbit, there's a septum, and if it's anterior to the septum, that's the more benign form, whereas posterior to the septum is more dangerous. So the difference is in orbital cellulitis, the patient will have diplopia or difficulty seeing and moving their eyes, blurry vision. And this will be treated inpatient with IV antibiotics, whereas preorbital is treated with oral antibiotics. And that orbital septum is the fascia that divides the front and back surface of the eyelids. So primary amenorrhea in a pediatric patient, the first thing you want to do is a pelvic exam or ultrasound to see if there's a uterus. If the uterus is present, then your differentials narrow down to Turner syndrome or hypogonadotropic hypogonadism. So the next thing you want to do is check FSH levels. Turner syndrome has the streak ovary, so their estrogen will be really low and their FSH will be really high. This child will also have a webbed neck, a low hairline, a shield chest, horseshoe kidney, bicuspid aortic valve, coarctation of the aorta, and streaked ovary. Their karyotype is usually 45XO, but if it's 46XY, which is a variant, that Y chromosome makes their streak ovary malignant, so you need to take that ovary out. The Turner syndrome kid will usually have problems growing to full heights and also developing secondary sex characteristics. So you want to supplement them with estrogen and replace that. And as they get older, give them growth hormone to help them grow to adult height. If the FSH levels are low, then this is hypogonadotropic hypogonadism, which is most likely which is a problem with the pituitary, and this is caused by excess stress or low BMI or malnutrition or excess exercise, which can be seen in extreme athletes. If the uterus is absent, then your differentials narrow down to Mullerian agenesis or androgen insensitivity syndrome. So Mullerian agenesis, once you're at this stage, what you want to do next is a karyotype. So Mullerian agenesis will be 46XX. So this is a genetically female person. They're just missing the Mullerian system and they have no uterus. And because of that, they aren't able to have periods. Whereas androgen insensitivity syndrome is chromosomally they're 46XY, so genetically they're male, but they have a defective testosterone receptor, and because of this, during development of the embryo, testosterone helps convert the vagina into the external penis and scrotum. And because they don't have this, then they have the external characteristics of a vagina, but they will actually have testicles internally and no uterus. So the person who has androgen insensitivity syndrome, those testicles can become malignant as well, so you want to remove those as well. And the reason why people with androgen insensitivity syndrome develop breasts is because excess testosterone floating around gets aromatized to estrogen, and then the estrogen causes the breasts to grow. This is the exact same mechanism as people who use anabolic steroids and why they can get gynecomastia. You should know these drawing milestones. I think of the PlayStation circle, X, square, and triangle, and it goes clockwise, starting with circle and X. That's 3-year-olds. The square is a 4-year-old, and the triangle is a 5-year-old. So these are the shapes a kid should draw by those age milestones. A parent is not allowed to refuse life-saving fatal treatment for a child. And if they do get a court order, the classic example is the Jehovah's Witness father who refuses for their kid to have red blood cell transfusion during some sort of emergency. The correct answer is transfuse anyway. It's normal for a newborn to get a period and have breast hypertrophy or galactorrhea. This is completely normal. You want to reassure the parent. This is due to retained maternal hormonal estrogen that is withdrawing. And eventually, it will go away. If a kid has recurrent unilateral pneumonia, think of some sort of blockage in the airway, like a foreign body, and you treat it with bronchoscopy. In adults, this is similar too, but think of blockage, but usually this is a cancer. Also, while we're talking about foreign bodies, in the pediatric population for yourself, anytime a kid has unilateral discharge from like the nose or the ear and it's really pussy, think of foreign bodies. They stick something up their nose or in the ear. Also with breathing, if it's like difficulty auscultating the lungs on one side or one-sided bronchi, then this is also a foreign body. And same with the vagina. In pediatric kids, if they have purulent discharge from the vagina, the most likely answer is foreign body. You should know between cephalohematoma, caput succidum, and subgaleal hemorrhage. So the most superficial one is caput, and caput is bleeding within the scalp. This does not stay put. It can cross over and move over suture lines, whereas cephalohematoma is subperiosteal, and this does not cross suture lines, versus subgaleal hemorrhage, which is underneath the aponeurosis of the muscle, and this is dangerous because they can bleed out, so it's an emergency. There are 2 cases where you need to remember: a kid with a large tongue and a protuberant abdomen with a umbilical hernia, and then these are kids who have cretinism or Beckwith-Weidman syndrome. Stable supraventricular tachycardia, give adenosine. Unstable supraventricular tachycardia, cardiovert. Stable ventricular tachycardia, amiodarone. Unstable ventricular tachycardia, cardiovert. Supraventricular tachycardia, narrow QRS. Ventricular tachycardia, wide QRS. The SVT looks like QRST, 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 and a ventricular tachycardia just looks like wide QRS, wide QRS, wide QRS. If you see jaundice on the first day, the next step is a Coombs test. Thymus, think of T cells. Tonsils, think of B cells. This can help you with the immunosuppressive diseases. If bone age is less than real age, this is a late bloomer. This is called constitutional growth delay. The dad and mom were probably late bloomers too. If bone age is equal to real age, this is familial short stature. The family is usually short too. A neonate is up to 1 month old. A kid who is 1 month-year-old to 1 year old is an infant. If the mom has hepatitis B, then you give the hepatitis B vaccine and hepatitis B immunoglobulin. Vaccines given at 2, 4, and 6 months are H-flu, DTaP, rotavirus, hepatitis B virus, inactivated polio, and pneumovax. Starting at 6 months, every year you can start giving influenza vaccines. At 12 months, that's when you can start giving live vaccines such as MMR. Niemann-Pick versus Tay-Sachs, they both have cherry red maculas. The only difference is that Niemann-Pick has hepatomegaly as well. The sail sign on an infant is on the right side of the chest by the heart. There's a sail-shaped kind of L thing next to the right atrium. This is the thymus. It's normal. An APGAR score less than 7, you intubate them if there's irregular breathing. If a newborn has a heart rate of less than 60, you're going to start doing chest compressions. If it's greater than 100, that is what you want to see. An APGAR score, so appearance, pulse, grimace, activity, respiration. So appearance, if they're pink and blue, that's 1. So I always think of the 1 scores, and anything that's better than that is 2, anything that's worse than that is 0. 0 is usually pretty much as bad as it gets, so it's pretty simple. So for appearance, if they're completely blue, that's 0. 1 is pink and blue, 2 is all pink. Pulse, if it's greater than 100, that's 2. If it's below 100, that's 1. If it's 0, no pulse at all, asystole, that's 0. Grimace is more like how much can you irritate or agitate them. So there's different ways to check agitation. So basically, if they have a strong cough, sneeze, or cry, or they are irritable, that's 2. If they kind of just grimace to pain, that's 1. If there's nothing you can elicit out of them, that's 0. Activity, if their arms are flexed a little bit, then that's 1. If they're freely moving around, that's 2. If they're completely flaccid and floppy, that's 0. Remember, floppy babies, there's 2 high-yield associations you need to know, Werdnig-Hoffman and botulism. And then last is respiratory rate. If there's a strong cry, that's automatically 2. Any irregular breathing is 1, and 0 is no breathing at all. Chickenpox vaccines are given twice, age 1 and 4. If there's a healthy person who has been exposed to chickenpox, who's never had it before and aren't immune, you give them a vaccine. If they're immunosuppressed and they've been exposed, you give the antibody. You can't give them the vaccine because it's a live vaccine. Choanal atresia, this is the key vignette, is cyanosis that's aggravated by feeding. Their nasal septum is obstructed. They aren't able to breathe out of their nose. So anytime they feed, that depends on them breathing through their nose, they'll start to turn blue. And it's relieved by crying because crying opens up their mouth. And you want to diagnose it with the NG tube. You put it up the nose, and then if you take an x-ray, you'll notice it doesn't go all the way down, or you won't be able to pass the NG tube through the nose. Failure to pass meconium. This is no stool passed in the first 48 hours of life. You have 3 that you should know about. 1 is imperforate anus, 2 is Hirschsprung's, and 3 is meconium ileus. Imperforate anus is part of the Vactorol criteria, and that's when you inspect the anus, or you can do an x-ray and you'll notice there's no anus, and then that needs to be fixed surgically. Whereas meconium ileus is from cystic fibrosis. You have the meconium plug from very dry stool that obstructs the terminal ileum, and they aren't able to pass stool. X-rays will show air dilatation proximal to the ileum, and you want to treat this with a water enema. Kids with cystic fibrosis, you want to supplement with the fat-soluble vitamins, D, E, A, K. You want to give pancreatic enzymes like lipase to help them absorb it. You diagnose it with a sweat chloride test. If it's greater than 60, that's CF, and pulmonary hygiene to prevent infections. Hirschsprung disease is associated with Down syndrome. This is due to failure of migration of Auerbach and Meissner's plexus. This is in the distal colon, so on inspection, you'll see a very tight anal sphincter, and when you open up the anal sphincter, there might be explosive diarrhea, and on x-ray, you'll see an enlarged distal colon, and then next thing you want to do is a biopsy, which will show that there's no Meissner or Auerbach plexus. and then to treat it, you're going to resect that section of bad colon. Treatment of hyperbilirubinemia: if it's above 15, you want to do UV light therapy. If it's above 20, this is severe, then you do exchange transfusion and exchange the blood. You need to know about breastfeeding jaundice versus breast milk jaundice. Breastfeeding jaundice is failure to feed, and because the baby is dehydrated, the intestine will absorb excess bilirubin, and this causes bilirubinemia. Whereas breast milk jaundice is a problem with the milk. The baby is feeding excessively, and milk actually has an enzyme that deconjugates bilirubin, and this unconjugates it and keeps it in the system. To treat breast milk jaundice, you want to reassure the mom to keep feeding, and eventually it'll pass. Rotavirus is contraindicated in kids with intussusception. Intussusception is also associated with Henoch-Schönlein purpura. Remember pyloric stenosis? This is the projectile vomiting in a kid who's 3 to 6 weeks old, usually the firstborn. It's very explosive. And then the abdominal ultrasound will show the donut sign. And this has a key association that it's associated with maternal macrolide use. Cataracts, think of rubella or galactosemia. Ureter pelvic junction obstruction: it's a teenager who drinks and had pain urinating that goes away after a few hours. That's because they have a narrow renal pelvis at the ureteric junction, and alcohol is like a diuretic, so it causes backflow into the kidney, which causes pain. C1 esterase deficiency is associated with angioedema, and then C5 to C9 MAC attack complex deficiency is associated with Neisseria infections. The first tooth that should erupt is the lower central incisor, and tooth eruptions happen normally between 3 and 16 months old. Pediatric milestones, everyone's favorite. 2 months old, you can lift your head. At 4 months old, you can roll over. At 6 months old, you can sit up straight. At 9 months old, you can crawl and start cruising, which means you can kind of stand up and hold yourself along with the couch as a crutch, and then cruise while holding the couch. And then at around 12 months, you should start being able to walk. At 1 year old, you should be able to say 1 to 3 words. At 2 years old, you can say 2-word sentences with hundreds of words, 2 zeros. At 3 years old, you can say 3-word sentences with thousands of words, 3 zeros. Object permanence happens at 9 months old. Separation anxiety happens at 6 to 18 months old. A red flag for motor development is if there's early hand dominance. That means the other hand is weak. Another thing is if a kid is showing language delay, the first thing you want to rule out is a hearing problem. Cerebral palsy, I want you to remember scissoring when standing. So when they stand up, their legs cross. This is a sign of cerebral palsy. Cerebral palsy is associated with hypoxia, vascular insults, or a premature baby. Vernix caseosa is a thick, white, creamy material found around the newborn. It's completely normal. Nevus simplex versus nevus flammeus. Nevus simplex goes away, nevus flammeus doesn't. Nevus flammeus is also known as the port wine stain. Strawberry hemangiomas are like tumor-like vascular formations on the skin. They go away with time, so reassure. DKA is a complication of undiagnosed type 1 diabetes or a type 1 diabetic who hasn't been taking insulin. This will manifest with anion gap metabolic acidosis, right? If you take sodium minus chloride minus bicarb and the gap is greater than 16, this is an anion gap metabolic acidosis. So for acidosis, the pH has to be lower than 7.35 and the bicarb has to be below 22. Then you calculate the anion gap. That's the first sign. They'll have glucose in the range of 300. The urine analysis will show positive ketones. Breathing problems, they will be trying to blow out as much CO2 as possible to compensate with respiratory alkalosis. And this is called Kussmaul breathing, which is deep, heavy breathing. They will also have nausea, vomiting, and abdominal pain. and this is DKA, and you treat it with a KISS. Potassium, insulin IV, and saline. Treatment of severe hypocalcemia is IV calcium gluconate. Red blood cell transfusions can cause hypocalcemia. So remember that, because all the products in the blood can bind up the calcium. And then treatment of hypercalcemia is intravenous fluids. And that's all for your pediatric shelf exam in third year. My advice is there's a lot of memorization, but there's a lot of also internal medicine too. If you haven't taken your internal medicine shelf yet, a lot of this knowledge will carry over into your internal medicine shelf as well. So it's a good investment of your time. The thing that's hard about the pediatric exam is there's a lot of random memorization. So in this video, I tried to give you some key buzzwords. It might not include the full picture because that'd be really hard to cover in such a short video, like the entire pediatric material. But try to remember those buzzwords I gave you. So I hope this video was helpful for you guys. Again, if you have any questions or need help, don't hesitate to leave a comment below. If you liked it, share it with your classmates. Yeah, I hope it was really helpful, and as always, we'll see you in the next one.